Yes, I expect, yeah, triploridine is correct. So if you look at that drug, so it is an unsaturated alkylamine, and we have said that the compounds. I don't know what is happening to this on my computer. So we are still agreeing that we are not having any new classes. Once you understand the first classes, then the classes again, the same classes are maintained. The only difference, of course, is there will be some structural differences to allow for the lesser, as we have said, penetration of the BBB. And that small text here. So you can see, so when we look at acrivastine, you can see what has happened is on our pyridine, on our pyridine, one, that's 1, 2 pyridyl, that's 3. Or at position 3 of our pyridine ring, we have introduction again of an unsaturated group. You can see there is double bond there. So this is an unsaturated group here. Of course, you have a hydrogen there, and you do have a hydrogen there. So that is an unsaturated group. And what is of most important, you can see the introduction of a carboxylic group there. Introduction of a carboxylic group there. And there's a double bond there. And if you look at that double bond, that means even in the substituent, there will be geometric isomerism. And it was established that the E isomer for acrivastine, the E isomer, meaning even for this group, the big groups, you can have that carboxylic group and that hydrogen there. And then on this side, you have this big group and this hydrogen on there. So this hydrogen and the carboxylic group are on the same side. So the big group, which is a carboxylic group, and that group. So the E there and E there was the isomer that was responsible for maximum activity. Introduction of this group here, the carboxylic derivative, decreases lipophilicity, decreases the ability of this group to penetrate the BBB, and therefore giving us less sedation. So acrivastine is a more modern non-sedating agent compared to the generation 1. It is related to triploridine and it's slightly more potent. Carboxylic acid substituent is responsible for the lack of sedation. Non-sedating agents have difficulty in crossing the BBB. Nothing new. That's all we have said. And we are looking at that drug. The only thing I've added here is that you require this to be the E isomer and you require that to be the E isomer. So the E isomer was found to be most active. Again, remember, you want a molecule, the smaller molecule that you still relate with the receptor appropriately. So we can say this is a carboxyethynyl moiety. Carboxyethynyl moiety was added on the 3 position of pyridyl ring with the increase in potency and decrease in sedative effect, and therefore giving us a better molecule with lesser toxicity. So that's the first one, which is a piperidine, which is an alkylamine, derivative, which is actually very similar to triploridine. Then so again, the same class is repeated, and this we already have mentioned. The piperazine derivatives, and the piperazine derivative, this again is a derivative of hydroxyzine. It's a derivative of hydroxyzine, whereby, remember, our cetirizine. That was our cetirizine, and then this was CH2OH. So this was an alcohol. So again, this was an alcohol, and that alcohol, can call it 1, 2, acetic acid derivative. Can be an ethoxy 1, 2, that's 1, 2 ethoxy acetic acid derivative, that's carbon-carbon. So that derivative is the only difference between cetirizine and hydroxyzine is that our alcohol, a hydroxyl derivative or hydroxyl group, has been further oxidized. Of course, first it will go to the aldehyde, and then it goes to the carboxylic acid, and retention of activity and improved activity that drug, because you can see here, this will undergo ionization at physiological pH. This will be protonated at physiological pH, that you carry the positive, that you carry the negative, zwitterionic, and at the same time, it has polar groups. You have an added, has a polar group, which will be the carboxylic group, and the drug also is behaving as a zwitterionic molecule responsible for better activity because it has lower CNS toxicity. It is a racemic, given as a racemic mixture. Why are we saying it's a racemic mixture? Because if you look at it, this carbon here, that carbon there is chiral, because that and that group are different. So that is chiral, and therefore it is given as a racemic mixture. And of course, the racemic mixture without being resolved is much cheaper. And of course, we did say when you resolve it and you get the pure, the levocetrizine, then you place it as a third generation. It's the primary acid metabolite of hydroxyzine, resulting from complete oxidation of the primary alcohol moiety, is zwitterionic and relatively polar, and thus does not penetrate the BBB. It is highly selective in its interaction with various hormonal binding sites and highly potent. The advantage of this compound appear to be once daily. Again, it has that big advantage. Cetrizine is a very popular, cetrizine, very popular antihistamine drug. It out there as Sizet, very popular, usually given as 10 milligrams once daily. Of course, as we have said, it will have minimal for different people respond differently to drugs. There's people who take cetrizine and they will still be sedated, but under normal circumstances, it has minimal toxicity, but it does cause people to feel lethargic. You feel lethargic. So more often than not, it's better to take it at night than taking it during the day. Lack of clinically significant effects on cardiac. Some of the drugs like the imidazole antifungals, and we will find that there are some drugs like tafenadine, astemizole, we will see they have a cardiac rhythm toxicity and therefore not very safe. So it has lack of clinically significant effects on cardiac rhythm when administered with imidazole antifungals and macrolide antibiotics. So why I've mentioned this is that it's a safe drug. You can, even when you take it with imidazole antifungals like ketoconazole, as you move on, you'll also start the old drugs. By the time you're done with you utaziba kama wimbo. You must sing them like a song, so that when you go out there, at least unatisha kidogo. People wanaona unajua madawa kiasi. So we are only saying when you give these drugs, like when you give cetrizine with imidazole antifungals, and I've given an example of an imidazole antifungal is ketoconazole. And macrolide antibiotics. Macrolide antibiotics, we have studied with you, azithromycin, erythromycin. Those are macrolide antibiotics. You find together, then you will get some of the bad drugs. You will get toxicity, and we're going to mention it. And we are saying, therefore, this drug is safe. It does not cause those cardiac rhythm toxicity. Most common side effect is somnolence, or where you feel lethargic in some of the patients, and therefore you are advised. It may interfere with the performance of certain psychomotor and psychophysical activities, and more often than not, you are advised not to drive, or more often than not, advised to take it at night, so that in the morning the effects have a bit worn out. And of course also to take care, to be careful of the activities you are involved in. As I have said, different people respond differently to different drugs. Even so, that some of the drugs that have no toxicity, to some of the patients have just a lot of toxicity. Just like you have seen, even with the COVID vaccine, you will find people who will tell you they got severe toxicity. The others who get very mild, the others who don't even observe anything. So please do note that we do have patient differences. We do have patient differences in terms of drug reactions and even drug activities, because you can have also differences in the metabolizing enzymes in different patients, or you can have also differences in the type of enzymes they have, and therefore the ability of those enzymes metabolize, or even in what we call polymorphism. You can have differences. You can have polymorphisms in different patients, or the enzymes have different types of they have different types of sequencing in their enzymes, and therefore you do have polymorphism. And when you have polymorphism, then where you have what you call rapid metabolizers, slow metabolizers. That can happen with some drugs, with different populations and with different people, and therefore you can get different toxicity. And a drug that is safe with you might not be safe in another patient, and those can be and therefore you it is important. That's why it is important to have pharmacovigilance and to be able to see how a drug, whether it is safe in a majority of the patients or it is only safe in a few of the patients. So it can be. So we are only saying that cetirizine, it can cause lethargic activities or lethargy, and therefore you must be careful which activity you will take on. For some of the patients, very safe. They will take it and move on to other activities. Then those were the piperazine derivatives. We have looked at the archelamine derivatives, piperazine derivatives, and we have the final one, I think. No, the last, no, we still have the piperidine. Then we have the phenothiazines. Again, I'm seeing no change in we are still having the same classes. It is only the structural differences used to treat allergic contraindicated liver disease, premature infants and neonates, drug interaction, enhanced effects on CNS depressants. And of course, here it will have enhanced effects on CNS depressants because of the fact that, again, it will penetrate BBB and also have depressant effects. As I said, it is a phenothiazine, and phenothiazines are considered to be major tranquilizers. So when you give it with CNS in drugs which is a CNS depressant, like you give it with sedative hypnotics like diazepam or benzodiazepine, you give them with the drugs like the benzodiazepines, whereby they are sedative hypnotics. You give this drug, which is also a major tranquilizer, then you have issues of a lot of CNS effects, or the patient might actually be highly depressed. Then also, when you give these drugs, you must be careful to avoid alcohol. Many of them are not very happy, but you tell them, if you cannot avoid alcohol, please don't take the drugs, because they can have fatal effects. Because alcohol at a certain dosage is depressant. These drugs can cause depressant effects, and therefore you must also be very careful. Why we give you some of these other effects is because when you are giving these drugs, you need sometimes to understand when the clinician is prescribing these drugs, they are supposed to ask the patient whether they are on other drugs. That's why they take history. And in taking the history, they're supposed to ask this patient, are you an alcoholic? Of course, most people will say no, but it is important to take the history properly. Is this patient on any other drugs? So that when they give these drugs, especially when the drugs that have a CNS effect, they do not cause a lot of the issues that we are seeing now, including suicide and what have you. So this drug, again, we are calling it mequetazine, again, has structural resemblance with the other one we had seen. It is only that this one now you can see this is an ethylene chain. Ring here is a bicyclic ring. So bicyclic ring is 1, 2, 3, 4, 5, 6. This ring on this side is a six-membered carbocyclic ring. The ring on this side is 1, 2, 3, 4, 5, 6. The ring on this side is a piperidine ring. So indeed, it is attached not to a piperidine ring, but it's attached to a bicyclic ring containing. Actually, the rings are the same on each side because they are also sharing the nitrogen. So both of them are heterocyclic rings. This on this side is 1, 2, 3, 4, 5, 6. So it's both of them actually piperidine rings because they are sharing the nitrogen. But it's a bicyclic ring, and of course, where you have that one carbon, another carbon. So two of the carbons are part of the heterocyclic ring with retention of activity. So that is the difference between this and the other, like promethazine, in that this drug has a bicyclic ring, and it actually has two bicyclic piperidine rings. Part of the carbon atoms are part of this bicyclic ring, and of course also it's a piperidine derivative with retention of activity, and more so being a second derivative, mequetazine being a second derivative rather than a first derivative or a first generation phenothiazine. Then the next one is the piperidines. Again, we have mentioned the piperidines, azatidine, cyproheptadine, and even ketotifen. So we have mentioned the piperidine again, structural modification of azatidine. Azatidine, we said it has an improved H1, first generation H1 antagonist, and it can be further improved. It can be further improved by structural modification. You can see we have loratadine here, whereby that is a pyridyl group, and this it shares with azatidine. You can see on the piperidine ring, you have this carboxy. You have that carboxy ethyl group, carboxy ethyl group. That carboxy group here increasing water solubility and making the drug non-sedative. And then, of course, you have tafenadine. It's also a piperidine. If you look at this drug again, you can see the two rings there, but it has a hydroxyl group. You have not seen any drug with a hydroxyl group there, and then attach your piperidine central carbon 1, 2, 3, 4, 1, carbon 1, 2, 3, 1, 2, 3. So you can see these two, the three carbons here. In fact, also the slightly prolonged ring, and with the three carbons, 1, 2, 3 carbons being part of a cyclic rings, again constraint and allowing that drug to be able to fit the receptor, and our terminal nitrogen being part of the piperidine ring, just as we had done even this. So that's why we are calling it a piperidine, slightly different in structure. It is not a tricyclic. You can see the two phenyl rings are not fused like loratadine, but it is a piperidine ring where it is not a tricyclic. So it's a piperidine ring where the terminal nitrogen is part of a piperidine ring, just like we have there. And then you can see on the piperidine ring, there is this group which has been introduced. If you look at the portions, that's a very small group there, small group there, and you can see what has been introduced. Tert-butyl phenyl ring. And this tert-butyl phenyl ring is the one which is further increasing the lipid solubility of this group, and this group is acting through having very high lipid solubility, and therefore having depotization, low concentration within the plasma, low concentration gradient, and therefore being retained in the lipid membranes within the periphery, and it does not penetrate the BBB to a large extent, but it will penetrate to a small some toxicity. So please note that group. We also have astemizole. Again, if you look at astemizole, it has a imidazole ring. That is a imidazole ring. It has a slightly different structure than we have seen before. You have that, it has an imidazole ring, and then it has that fluorophenyl group, fluorobenzyl group, and it has an imidazole ring, but it is still a piperidine derivative. Very different from it has a slightly different structure from the others, but you can see that carbon attached to a nitrogen. We have not seen any other drug because the others was where that nitrogen, that this is an oxygen. So the ethanolamines were having this as a nitrogen, but you can't see because of the change of the structure. Remember, we did mention that you cannot change that oxygen with a nitrogen. You will lose activity. But for you to change the oxygen with the nitrogen as in astemizole demands for you also to change the hydrophilic group or the lipophilic group. You can see it's a benzoimidazole attached to a fluorobenzyl group with retention of activity. So that is our astemizole, again a piperidine derivative. Previously, prior the emergence of HIV and AIDS, both tafenadine and astemizole are very good drugs. But now, because of the emergence of HIV and AIDS, there has been found that there is a lot of drug interaction, and these two drugs have actually, in most countries, they have been from the market, and we're going to discuss that in a minute. So those are some of the three drugs, the three derivatives of the piperidine derivatives, tafenadine, astemizole, and loratadine. And we are saying, as when we look at loratadine, just like in azatidine, the chloro group, the pyridyl group are responsible for increasing the activity, and the carboxy ethyl group being responsible for introduction of water solubility or polarity, and therefore that drug having lesser ability to penetrate the BBB. So that is azatidine. You can remember our azatidine there. So you can see our azatidine there. It does not have the chloro group there, but it does have the pyridyl group. So you can see the loratadine and azatidine are structurally similar with a chloro substitution and a change. You can see that change there, introduction of that carboxyl group there, increasing the water solubility, that drug the non-sedating effect. So loratadine is a non-sedating H1 antagonist with no anticholinergic side effects. Introduction of a chloro and a carboxyethyl group increases potency, and also the carboxyethyl group decreases the ability of this molecule to penetrate the BBB and therefore lower CNS toxicity. If you look at this, is a carbamate, which is also an amide. Being an amide, it will be stabilized by resonance, that these nitrogens will come in, this will go out, and therefore you find that the carbamate, the loratadine, let me reduce the size, please. You find that what has happened? So let us go back. Go to the internet has disappeared. 1 minute, I get it. Not decrease. So all we are saying is that because of this amide group here, stabilized by resonance, the nitrogen here therefore does not have a lone pair of electrons. Neutral. Since carbamate nitrogen is neutral, it is rapidly absorbed, and it's a quick acting drug. So we are saying this nitrogen here lacks basicity because of the fact that it is stabilized by resonance, rendering that nitrogen basic. And if it is, neutral, it means it will not be protonated. If it's not protonated, it is telling us it is less ionic. So it's not, since carbamate rapidly absorbed and rapidly absorbed, because if it is not protonated, it is not charged, it is not ionic. So therefore that is allowing it at least to have some lipid characteristic. Remember, you must also have lipid characteristic for ability of that drug to be absorbed, because if again it is highly high, you see you have introduced a polar group. So you also reduce the basicity, it reduces the basicity of that, making that molecule, that piperidine molecule, or the piperidine ring neutral, and therefore this nitrogen is not protonated, allowing that molecule to be absorbed. Because it requires to be absorbed, it will go into water well, it requires to be absorbed, it requires to penetrate the membranes well, and therefore it is rapidly absorbed and is quick acting. Loratadine, that is the same. This drug is extensively metabolized primarily to the discarboethoxy metabolite, which retains some antihistamine activity. Discarboxyethoxy means you remove the whole of this group. Discarboxyethoxy group, you remove the whole of that group. The whole of that group is replaced with the hydrogen, and still that metabolite has still been found to have some activity. So that is loratadine, the first drug within that category, loratadine, which is a derivative of azatidine by addition of a chloro group, addition of an ethoxy carboxyl group, or addition of a carboxy ethyl group, which helps in increasing the water solubility, and of course the chloro group increases the activity, and therefore that drug does not readily penetrate the BBB, resulting in lower CNS toxicity. The other drug is tafenadine, and as we look at this tafenadine, it's a tert-butyl. So all those methyl groups, and this is the group you have added there. That group brings in. So from this, remember most of them and perhaps CH3. So you have added the whole of this group. Indeed, when you look at the antipsychotics, you will look at one class, which we call the butyrophenones. The butyrophenones is a class of antipsychotic. Indeed, the tafenadine is considered to be structurally resemble the butyrophenones. Here, there's a double bond O. So it resembles, it's like a reduced butyrophenone. So you find that this group here, which is highly lipid soluble, gives this drug very high lipid solubility, and therefore the drug, as we had said, there is deputization, the drug is retained within the periphery. Tafenadine is a reduced butyrophenone. As I have said again, the butyrophenones are very important drugs. You look at them, whichever way you look at them, as a second class of the typical antipsychotics. I've said some of the antipsychotics are the phenothiazine. Another class of antipsychotics is the butyrophenone. So you can still see sharing of structures. The butyrophenones are antipsychotics. Tafenadine, which is a reduced butyrophenone, is an antihistamine. So you can see that there is a lot of structural resemblance between these drugs that have CNS activity. So derivative without antipsychotic properties, that's the only advantage. It's a reduced butyrophenone, but it doesn't. It has moderate potency, devoid of sedation side effects, with a long duration of activity. Tafenadine shows no significant anticholinergic activity or at any other receptor. So this is a good drug from this effect. But as I said earlier, the only most unfortunate drug, the issue is that when you give tafenadine with imidazole, antifungals like ketoconazole, all with the macrolides like erythromycin, like azithromycin, you find that this drug and these other imidazole antifungals and the macrolides all use the same drug for metabolism, use the same enzyme for metabolism, and therefore you find that when you give this drug with those antifungals and the macrolides, the concentration of this drug goes very high. And when the concentration of this drug goes very high in the body, same case with the stemizole, these two drugs cause what we call torsades, the pointers. They cause cardiac toxicity. They cause cardiac toxicity where the QT interval is prolonged. They will prolong the QT interval. And I've said the reason for the toxicity is when you give them together. And of course, we do understand with HIV and AIDS, you can give, the person can have pruritus. So you decide to give them tafenadine. The person can have fungal infection. You decide to give them ketoconazole. The person could have also bacterial infection. You decide to give. You can see how a toxicity which was not earlier discovered. It was not discovered when this drug was being studied, because at that time there was no need to give this drug together with antifungals, together with perhaps antibiotics, but with the emergency of HIV and AIDS, where the use of antifungals and antihistamines can be a lot, there can be increased use of antifungals and antihistamines concurrently, their toxicity was observed, again through pharmacovigilance. That toxicity was observed, and indeed for some of the patients it was actually fatal, and therefore this drug together with astemizole were withdrawn with it from the market. So we are saying the antihistamine activity is attributed to the diphenyl methyl piperidine half of the molecule, diphenyl methyl piperidine. You look at this, diphenyl methyl piperidine. So this group there is the one which is responsible for the H1 binding. So the antihistamine activity is attributed to the diphenyl methyl piperidine half of the molecule, while the other half is responsible for the lack of affinity for other receptors. We have said that we have this drug is safe. So this area, remember, if you look at this area, surely there's a lot of similarity in this area and the other antihistamines. Two phenyl rings, 1, 2, 3, the terminal is nitrogen, is protonable, because that with minus, so that nitrogen is protonable, that nitrogen is tertiary, there is the spacer, there is the bulk group. So those are, this area here is looking like all the other antihistamines, the diphenyl, the ethanolamines, It is looking like the other alkylamine derivatives, because you can't see these are carbon. But you do have, so up to there, you also have this. These are the group there. There's other portion of the molecule is what we are saying is responsible for this drug having selectivity for H1 receptor. So the diphenyl methylpiperidine half of the molecule is attributed, that gives us antihistaminic activity, while the other half is responsible for the lack of affinity for other receptors. It is non-sedating H1 antagonist because it is too lipid soluble, as I already have said. Too lipid soluble, what that needs to be explained, meaning there will be depotization concentration in plasma. I've already explained that. It has a long duration of activity due to its low dissociation from the receptor. It undergoes extensive fast-pass metabolism. And the reason why it undergoes extensive fast-pass metabolism, whenever you have an alkyl group attached to a phenyl ring, this methyl, one of either of these methyl groups, they are all equal, can undergo oxidation fast to the alcohol and then to the carboxylic group. When it forms a carboxylic group, it changes the phenadine to fexofenadine. So fexofenadine is a metabolite of tafenadine. So it undergoes extensive fast metabolism, but has a half-life of 20 hours, has drug interaction with ketoconazole and erythromycin. All three are metabolized by the same enzyme, the cytochrome P3A4. So because of the fact that of this metabolic drug-drug interaction, is because ketoconazole, erythromycin, and tafenadine are all metabolized by the similar enzyme, which is a cytochrome P3A4. And because they are metabolized by the same enzyme, if you give these drugs concurrently, therefore definitely the metabolism of tafenadine will go down to fexofenadine. Fexofenadine is a safe drug, does not have that side effect. So once the metabolism of tafenadine goes down, there will be much higher concentrations of tafenadine than what is safe. And that is what will cause the cardiac toxicity. Ketoconazole are inhibitors. So because whenever they are metabolized by the same drug, the same enzyme, it will look like those other drugs will act as inhibitors of also cytochrome 3A4. They slow the metabolism of tafenadine, allowing blood levels to increase significantly. So they are metabolized by the same drug. And not only that, also these drugs are also inhibitors of cytochrome 3A4. So there is that double effect. This metabolism by the same drug, therefore competitive inhibition, and therefore also they are inhibitors of cytochrome 3A4. They will increase the concentration of tafenadine, and the minute you have get high levels of tafenadine, these high levels produce a cardiotoxicity, QT interval prolonged, and arrhythmias. So that's a cardiotoxicity where the QT interval is prolonged and you have arrhythmias, which can prove fatal. This led to its removal, and it was replaced by fexofenadine, and fexofenadine is a metabolite of tafenadine. So you do not require to give tafenadine, because the problem is, although it is being metabolized to fexofenadine, it also has a long duration of action, up to 20 hours. It can remain in the body for 20 hours, and therefore it will also bring its toxicity. So now you remove tafenadine and you replace it with fexofenadine. That condition where the QT interval arrhythmias is where the condition we are calling Torsades de Pointes, which is switching of the spikes. So the spikes are switched. You know there is a normal kind of what do you call that? Is it the ECG? Electrocardiogram. Yeah, it is a ECG. It should show the normal spikes. But when you give these drugs together, there will be a switching of the spikes, or there will be a prolongation of the QT, and arrhythmias, and that is the Torsades de Pointes result, which can actually result in death.